today's panel. And I'm going to let Amy Campbell introduce the panel, but first I want to introduce Amy Campbell, and she gave us 4 lines. And I'm just going to say to those of us who know Amy Campbell, she is an illustrious member of our department. Many of us have worked with her. The 4 lines she gave me are: Amy is a professor of clinical psychiatric social work in the Department of Psychiatry at Columbia University Irving Medical Center, and she's a research scientist in the Division of Substance Use Disorders at the New York State Psychiatric Institute. That's going to change soon. She's been involved in addiction treatment and implementation research, primarily in community settings and in partnership with community providers and consumers for 30 years. She's up there with me. But really importantly, she's been an important colleague and teacher and mentor to many of us, myself included. She is on the Statistics, Data Science, and Data Management core of the HIV Center. I know, Susan, you've worked really closely together, and I could say a million more things, but then we'll never get to the panel. So Amy is going to introduce today's panel.
All right. Well, thank you so much, Claude. That was very kind of you. We all set to go? Oh, yeah. The license. Yes. Great, thanks. All right. Yes. So thank you again, Claude. And I told Claude I just updated it to 30 years from 20 years because you do it in decades. So I was really young yesterday, and now I'm less young today. And good morning, everybody. Thank you for those of you who braved the rain and came in person, and welcome to everybody online. So I am really excited to introduce today's panel, which I'm honored to moderate briefly. And I'll just say that this is part of a series, kind of a formal, informal series that we've been doing within the HIV Center to really bring forth implementation science and issues around implementation science as it concerns HIV risk, prevention, treatment, recovery. So our prior implementation series topics looked at like hybrid trials and how to utilize those, and really trying to focus on kind of application of implementation in the real world and how it can relate to our work. I always like to put in a plug that, implementation science is not just for quote unquote implementation studies, but we can integrate implementation science across the translational research spectrum to really try to understand real world factors earlier in the research process. So take what we're sharing today and try to integrate it as much as possible into your work. Our goal for today, the title of our panel is Leveraging Implementation Science to Integrate Substance Use and HIV Service Delivery. And so I think we probably can all agree that most of our work is focused on integration to some degree or another. We know that anything that we study, any issue that people struggle with, doesn't happen in a silo or a vacuum. It happens in the context of complex lives and complex systems in the world. And so we really wanted to take this opportunity to focus on integrated care, and specifically with HIV and substance use. And I just want to introduce our panel for this morning. And as you can see on the right-hand side, I've just given you kind of just a brief, 2-line synopsis of what each of our panelists is going to be talking about today. And I hope that you can see, we tried really hard for you to see kind of the thread that runs through these things. So we're going to start with Christopher Ferraris, who is going to talk about some of the epidemiology of HIV and substance use and integrated care, really a snapshot of the last 2 years. And Chris is the scientific coordinator for the HIV Center and a doctoral candidate in social work. He began his career providing direct clinical services to people living with HIV in New Orleans during his LMSW internship, and he's remained deeply engaged in HIV work ever since. His research aims to center the crossroads of HIV, mental health, and substance use with prevention behavior, HIV prevention behaviors, and biological vulnerability. Sorry, that's not you. I just skipped down to Justin. It sounds really good though. Sorry about that. So let me just say that Chris's research aims to center the crossroads of HIV, mental health, and substance use with a strong emphasis on translating research into frontline clinical care and best practices. Next, we'll hear from Dr. Justin Knox, who's going to talk about an emerging method that he's developing and evaluating to inform the integration of multi-component interventions. And Justin is an assistant professor of clinical implementation science and intervention at Columbia University. His research focuses on HIV and substance use among racial and sexual minorities, both domestically and globally. Among other grants, he is currently the MPI of an R01 study that seeks to investigate relationships between cannabis use and HIV prevention behaviors and biological vulnerability to HIV infection among Black men who have sex with men. And then our last presentation, before we open it up to some discussion and dialogue, are from our colleagues from the New York City Department of Health. And they're going to be talking about a really cool applied example of an integrated service program for clients in the real world, and looking at methamphetamine, HIV risk, behaviors, prevention and treatment services. And they utilized an implementation science framework to think about the evaluation of the two programs that they're going to talk about today. So Dr. Cristina Rodriguez-Hart is an Afro-Cuban and white researcher who is passionate about eliminating stigma, combating inequities, and advocating for social justice. She serves as a senior research scientist for the New York City Health Department, where she leads a team responsible for evaluating the impact of ending the epidemic and Ryan White Part A funded services on health outcomes. She devotes much of her time to educating HIV service providers, researchers, and governmental representatives on the negative impacts of HIV-related stigma. And she will be joined by her colleague, Connor Reynolds, who is a data analyst in the New York City Health Department's Bureau of Hepatitis, HIV, and STIs, and specifically in the HIV Care and Treatment Program's Research and Evaluation Unit. His primary responsibility is to provide data analysis and reporting to evaluate and plan New York City tax levy-funded HIV programs, including process and outcome data aimed at measuring reach to populations, assessing intervention effectiveness, and improving service delivery. So that is our esteemed panel. That's the content we're going to get through today. And before I turn it over to Chris to get us started, I just wanted to give us a baseline definition of integrated care. And both Chris and Justin are going to talk a little bit more about what is the conceptualization of integrated care, what is it? And as we all know, I will just add from the get-go that it's complex. So here's a really, really brief definition. It really brings together two things: the design and delivery of care systems that are historically fragmented. That's the integration part. And then what we really want to do is optimize care. We want better outcomes for our clients and patients. So those are the two components. And then in the blue circles, you can just kind of see some of the characteristics of integrated care. We want to focus on the continuum of care. It's often multi-level, multi-site. That adds to the complexity. We want to increase connectivity, collaboration, alignment of services. We want to enhance quality, efficiency, and satisfaction. So we can talk to our, policy and administrative partners are really interested in integrated care for those reasons. And I think, one of the most important things is the person-centered component of integrated care. That's what we're really striving for. So for today, we want to take that definition and in the context of these presentations, and we want to think about how do we move beyond descriptions of integrated care to guides on how best to implement that. How do we do it? And along the bottom, there's a few questions that we've developed that we just want to have you all kind of just have in the back of your mind as you listen to these presentations. And then hopefully at the end, we can kind of think through some of these complexities together. So what steps can we take when integrated care is implemented, but effectiveness outcomes are variable or mixed? Can we improve implementation outcomes by systematically packaging interventions to deliver integrated care? What does systematic implementation of integrated care look like in the real world? And can we use those examples to further scale up? And what does that look like? And then maybe for us to really think about some of the best practices for community research, community technical assistance partnerships. How do we do that to really support implementation work around integrated care? So with that, I'm going to turn it over to Chris, and we'll get started.
Thank you so much. Oh, I'm just gonna see that. Through. Stop sharing here. And then go over here. Sure. Which. And I think. Can't see really well. Is it this one?
No, that's the policy.
Oh, okay. This one?
Fatal substance.
Yes.
Substance laws.
That's right. Thank you, everyone, for being out here in some rainy weather. I wanted to open this with a review that Justin, Christopher Magana, and I did. There's a punchline to this review that I think is very complimentary to this larger panel on implementation science, and I'm not going to name what the punchline is just yet, but it was just recently published in Current Opinion in HIV and AIDS. We'll talk to you a little bit about the methodology, but our overall objectives were to conduct a narrative review of recent domestic empirical studies on substance use and HIV care, which included epidemiology, the recent evidence on the prevalence of substance use among people with HIV, what integrated care models are there and how are they being implemented, but more so the extent to which implementation science frameworks are being used to guide evaluation and scale up. And that was sort of our main focus of the past 2 years, which is the typical model for current opinions in HIV/AIDS. What has implementation science, how has it been used, what frameworks? So, I will go through this very quickly. Substance use disorders are prevalent among people with HIV. We all know that. They're consistently linked across the care continuum, which is retention and care, ART adherence, and then finally viral suppression. We know that integrated care models have benefits for both substance use and HIV care. And as Amy pointed out in the introduction, they're still nebulous in how they're conceived of, or what is quote unquote integrated care. There's a growing number of integrated care models that are being tested, but it's still very mixed in how they're directly affecting viral load outcomes. And so we're seeing some ancillary outcomes that do get affected, like engagement in care or certain psychosocial stressors, but we still don't see clear evidence that they're directly impacting viral load outcomes. And what we also know, implementation science offers a number of frameworks to help understand how to implement and evaluate these integrated care models with a focus on barriers, adaptation, support, sustainability, and scale. So our review really looked at, again, this very rapid review in the past 2 years, beautifully only 2,500 words, which is a lovely word amount for a paper. What's been happening in the past 2 years? We used very typical methodology for this. This was on recent literature. We used the common databases. We used the search terms HIV care, substance use, integration, and implementation. And it included studies that examined substance use within HIV care settings. So screening, treatment, linkage and referrals, and digital tools. Those are all sort of things that that we came. And we'll talk about some really interesting studies that came up. We found 18 peer-reviewed studies within that period. Settings included HIV clinics, mobile units to mobile health and behavioral interventions. The epidemiology really re-echoed what we already knew. Substance use disorders were common among people with HIV and consistently linked to care cascade barriers. There were 2 studies from the National Survey on Drug Use and Health. The first found significantly higher rates of past year tobacco, cocaine, meth, and heroin use compared to HIV-negative peers. The second one found that Black people living with HIV had higher rates of alcohol use disorder compared to white, non-Black people with HIV. The Women's Interagency HIV study paper found that 27% prevalence of cannabis use among the women within this cohort, the WISE cohort, with about 15% daily use. And women using cannabis reported alcohol, cigarette, and other drug use more than those not using cannabis. So that was an important finding. And then one really interesting study that did latent class analysis found that youth 15 to 24 found that missing or no HIV care in the past year was most prevalent among the class with the highest probabilities of alcohol misuse and marijuana misuse. So this epidemiology section did not shed more light, but nothing new. It only expanded what we kind of already knew, that there were disparities within this realm. These were 5 of probably the most interesting studies that were out there, and so I just wanted to highlight them very quickly. So the first one, the last author, it was an mHealth app where participants completed weekly surveys about their health status, their confidence in HIV care, and about adherence. But not only did it have this weekly monitoring, it also had what they called network expression, which was, I'm going to post to forums, I'm going to message to other people that are on this app and talk with them about HIV care, and et cetera. And that's important. They recruited about 208 people with HIV with substance use disorder in 2 US health clinics. And this integration approach was bringing this app, this weekly monitoring app, and this network usage back to the medical provider for review, for chatting. I think it was on about a monthly basis. What the outcome was that intensity and not initiation predicted medication adherence, which is really interesting. So it wasn't enough to just sign these folks up with the app. They needed to use it. And they were just measured through raw clicks. So the higher amount of clicks were also correlated with better outcomes. But what's really interesting is when they stratified by race, Black participants, the effect that had the most outcomes were the network expression parts. The weekly monitoring, the weekly monitoring of substance use, of HIV adherence, that really didn't show an effect. It was using the forums and it was contacting other people that were using the app. Those were the most predictive of better outcomes for these participants. And what was really interesting is that among white participants, really nothing was found super effective in increasing adherence to HIV medications. It was only that network part that occurred among the Black participants in the cohort. So the take homes is that the focus on intensity of the system engagement rather than just engagement and initiation alone. METCH, of course, who is known to Columbia, Project Retain randomized control trial focused on cocaine using people with HIV in Atlanta and Miami. It looked at a patient navigation with CBT, cognitive behavioral therapy, and motivational enhancement therapy embedded in HIV care versus the treatment as usual. Substance use treatment participation and engagement much higher in that intervention arm, 87% versus 7% for treatment as usual. Distress lowered consistently, or distress was variably changed throughout the trial, not consistently, but no difference in viral suppression. So we're still seeing not clean viral load outcomes in an integrated model. Engagement improved, but we still didn't see that viral suppression gains happen. This is a really great study, this next one, Maitani, which was the first study that looked at the feasibility of long-acting injectables in a very, very low threshold clinic, mostly serving people with precarious housing and substance use disorder, unstably housed people with HIV in San Francisco, 18, I think the overall sample was 33, but they were put on long-acting PrEP. So I'm just going to focus on the 18 people living with HIV, a high prevalence of opioid use disorder and methamphetamine use. And the setting was co-located HIV care plus this long-acting ART plus intensive support. And at the end, 93% viral suppression and 92% on-time injections for very precariously housed individuals with high opioid use disorder. There was a line in that paper that was just really extraordinary. Among 8 participants, they were never virally controlled in outpatient oral medication, and long-acting injectable got them to viral suppression. It was a high-intensity support that can yield strong outcomes, especially among a very vulnerable population. And it was really the first feasibility trial that looked at long-acting injectables among this population. Zelenev looked at a non-inferior randomized control trial for holistic health for HIV, which is 3H plus, versus HHRP plus, which is a CDC EBI. The goal of this is to maybe have a lower threshold of the CDC EBI, which is 24 contact hours of an intervention, which is, of course, really high intensity for any setting out there. So they looked at 4 one-hour sessions plus a 5th one-hour booster among people in New Haven with opioid use disorder, people living with HIV. It was found to be non-inferior in terms of sharing needles and attainment of viral suppression. So the take home is brief models may be just as acceptable or scalable as these larger models. And I know for any clinicians or providers in the room, 4 or 5 hours is much better than 24 hours of intensive management. And then lastly, the collaborative care model pilot, depression and opioid use disorder in Seattle, a low barrier clinic. They looked at bringing in a psychiatrist full-time on a co-located care model, 36% screened, 15% intake, and 9% engaged. It was found to be acceptable and feasible, but multiple barriers. And staff that just basically saying, I forgot that we could even sign them up for this. We're really kind of, I'm going to pass it on soon. So most interventions were feasible and acceptable, but had limited reach and mixed effectiveness on viral load suppression. It was better at improving intermediary outcomes. Peer navigation, digital tools, co-designed, and patient-centered approaches show promise. Here is finally my punchline. Of 18 studies, only 1 used an implementation model. It was using CFR to guide some primary care, to guide some primary data collection, but the remainder did not use integration or did not use implementation science in any way. And of course, they might be using it when they're writing it, but they're not specifically writing it into that article. So future work requires more systematically measured implementation science outcomes. And then takeaway, so we're still seeing sustained high rates of substance use among people with HIV. It's negatively impacting HIV care outcomes. Integrating substance use services into HIV prevention can improve. We looked at some models that looked at co-located clinics, mobile outreach, and behavioral health integration. It's feasible and acceptable. We're still not seeing those clean direct effects though on viral load suppression. And in implementation science, 1 out of 18, it's consistently being underused when looking at these studies. So I'll stop there and I'll now yield to colleagues that are actually doing a lot more in implementation science. So let me just share really quickly. I'm going to, hold on a second. Oh, thank you. Thank you. I'll do stop share. And this is yours, Justin? Yeah. And oh, shoot. How did it do that? This was it.
Yeah.
And I'm gonna hit this again. Why does it keep doing
Increase that, minimize that window.
that? Yeah. The view here is really hard.
Maybe do it as a slideshow and then share. The slide. I mean, maybe it's sharing that.
And I pass it on to you. Are you getting it?
So it's sharing right now.
Drag the window up, I think you can see it.
Oh, okay, so drag the window up a little.
So what don't we do is screen share.
Oh, okay, perfect. Yeah, you got it.
And now, where's the,
You go down to share.
yeah, where's the share button?
Here, go up. Gotta go over on this.
Oh, is it up front?
Yeah.
Oh,
And hit share. And then share.
all right. We can all see that? Okay, we're all good? All right. That was great, Chris. A lot of detail in a short amount of time. But I will say it was a very nicely done review, very clearly written, and anyone can read it, right? It's available on PubMed, and nicely done. And I think there's some I think it's a nice segue to what I'm going to be talking about, right? Talking about the potential benefits for integrating substance use and HIV care. And so I'm going to be presenting on a method that we developed for creating multi-component integrated interventions by combining existing evidence-based interventions. We named the method the collaborative method for building interventions from existing evidence-based interventions, or combined EBIs, and it's available through PubMed, but also free full text. We paid for open access, so we're hoping that this is a tool that people are interested in and find useful, and then can access wherever they are. And just wanted to say that this work is done under the auspices of a KO1 award. That award is titled Intervening to Improve HIV Treatment and Reduce Drinking in People Living with HIV. So yeah, just to relate what I'm talking to a little bit more explicitly to these other talks, when we say integration of health services, that refers to the intentional coordination of services, systems, and interventions to address multiple health or social needs simultaneously. Integration can be needed to bridge siloed systems. It involves aligning services, workforces, and funding streams to provide person-centered continuous care. And we feel that multi-components are another important example of integration. And this is a method for creating these multi-component interventions. So the justification for multi-component interventions, right, is that many health issues are complex and co-occur, right? Chris provided us some evidence, some recent evidence about how substance use and HIV often co-occur, right? And thus they often require multi-level approaches, right? And addressing these issues together is a shift towards whole person health, right? And oftentimes addressing one issue and not addressing another co-occurring issue does not necessarily lead to gains or benefits in the other, right? Sometimes you need to explicitly create interventions or provide services that address these co-occurring issues simultaneously, right? So combining evidence-based interventions creates multi-component interventions that can address syndemic and interrelated conditions simultaneously. We hope it can improve efficiency and resource use, as well as enhance adoption and accessibility within a real-world practice setting, right? And leveraging existing evidence-based interventions is a research-efficient strategy that maximizes prior investments and strengthens implementation science goals to increase the uptake and impact of existing evidence-based interventions. So with that background, I hope it's clear, why combined EBIs was needed. And so now I'm just going to spend the rest of my talk describing what it is and why we felt it would be helpful to publish it. Right, so combined EBIs is a structured approach for developing multi-component interventions. We felt that specific guidance on how to combine evidence-based interventions is lacking, despite the proliferation of study designs to evaluate the delivery of multiple interventions simultaneously or in sequence, such as most, SMARTS, etc. Combined EBIs emphasizes collaboration, community engagement, as well as transparency and efficiency. And I think why this matters, especially now, is that we all realize that public health and research, we face limited funding and workforce capacity more than ever, right? And combining EBIs is a resource-efficient way to amplify the impact of existing evidence-based interventions, right? Imagine if you're developed or are working with an evidence-based intervention, you potentially could increase its uptake and impact by bundling it with other interventions or integrating it into other service deliveries, right? So we feel that uptake of combined EBIs would support the rapid and increased translation of evidence-based interventions into practice, which, as I said earlier, is the goal of implementation science. So this is a figure 1 from the paper, and we included it because sometimes a figure can be helpful to see the steps, right? But there are 5 steps that we conceptualized in this process of combining interventions. The first one is to identify and select the evidence-based interventions that you'll be working with. The second is to develop a shared conceptual model to think about how all the different components, what's relevant and how do they interrelate. Step 3 is to evaluate the conceptual model. Step 4 is to create a single combined protocol. And then step 4 is to refine that protocol through further input. And I'll describe these each in more detail, particularly how we applied it in this project. And this is another table taken from the paper that describes the activities that are involved in each of these steps, as well as key considerations to take into account while you're doing this. And as I mentioned, I've had great mentorship on my K in general, but with this paper especially, and really thinking about how to make this publication useful for others that are interested in following this process and using it as part of a K award or an R34 award application, but also if you're in practice and thinking about actually delivering services simultaneously, can we create materials that that could be used by others and shared and help people actually apply this process and do this. So for step 1, to identify and select evidence-based interventions, in my case, this stage happened as I was writing my K01 application. It was an iterative process. We engaged in the research literature to think about what are important co-occurring issues. I also what's the epidemiology, what's the support for combining interventions. I also discussed this with peers and mentors. You could also engage potential users of the information as well as potential implementation partners to understand their priorities and interests, as well as resources that are available. And really, I think we really thought about this more in retrospect. It's never too early to start engaging community and providers to be thinking about, what are their priorities. And so I eventually identified 2 evidence-based interventions that I've been working with for the past 5 years. One is called Engage and the other is called Health Call. And I'll describe sort of right now scientifically why I felt it was important to combine these 2 interventions, one focused on HIV care and one focused on supporting reductions in alcohol use. So there are over 1.3 million people living with HIV in the US. This is the most current data on the HIV care cascade. Current ending the HIV epidemic and UNAIDS goals are to get to 95, 95, 95 in order to achieve epidemic control, but we're well short of these goals, right? And there's many people living with HIV who need evidence-based interventions to improve HIV care outcomes. Alcohol misuse, including alcohol use disorder, is common among people with HIV, right? We saw that in Chris's review. And this recent meta-analysis showed that the pooled prevalence estimate of alcohol use disorder among people living with HIV is almost 30%, right? So this is a prevalent issue. And we also know that alcohol use interferes with HIV care outcomes, right? So this is VA data showing that there are worse outcomes across the HIV care continuum by increasing levels of alcohol use. So we felt there was epidemiological evidence supporting the benefits to combining interventions that address these issues simultaneously. And so then we set about to identifying and selecting those as evidence-based interventions. The first one identified uses a social network approach to improve HIV care outcomes among people with HIV. It's called Project Engage. It was developed by John Schneider at University of Chicago, who's one of the mentors on my K Award. And Project was designed for young Black men who have sex with men who are newly diagnosed with HIV. In the HIV clinic, they would complete a social network exercise to identify a social support member who could provide social support to them in their HIV care. And then that social support member was invited to the HIV clinic, and the intervention is actually focused on both them and the index participant and training them how to provide HIV care specific social support. The intervention was found to be effective in improving HIV treatment outcomes in a multi-site randomized clinical trial. Although it does not explicitly address alcohol use. And since this is a salient issue among many people living with HIV, we felt it could be enhanced by integrating support for explicit support for alcohol use into that intervention. So the second intervention identified was called Health Call. It was developed by Debbie Hassan here at Columbia, another of my K mentors. And that's a mobile health intervention that targets reducing alcohol use in people living with HIV. Participants in Health Call trials participate in a brief baseline counseling session, oftentimes using motivational interviewing, where they develop drinking reduction goals. They're then trained to use the Health Call app and encouraged to use it daily to answer 2 to 3 minutes of questions to track their drinking behavior, as well as their HIV medication adherence over the past 24 hours. They then have follow-up sessions with a counselor at 30 and 60 days, where Health Call can provide visualized feedback on their drinking, their alcohol use, and HIV medication use patterns over those past 30 days. And over multiple trials, Health Call has been shown to reduce drinking and improve HIV medication adherence. And we're really at the point where it felt like it's been shown to be effective and could benefit from further scale up and dissemination. And we felt that by combining it with another existing evidence-based intervention could be a way to possibly do that. So then step 2 also happened during the grant application, but this was to develop a shared conceptual model, right? I wanted to map out the key constructs, the intervention activities, the behavioral outcomes and clinical outcomes, and then hypothesize about how they could be associated, right? In this case, we had social network engagement, mHealth engagement, and thinking about how those relate to both substance use and HIV care engagement, and now those could have downstream impacts on HIV health indicators such as viral load and CD4 count. So then step 3 was to evaluate that conceptual model. This became aim 1 of the K Award, and which I think, it can be typical and useful, even like essential to conduct this type of formative work. Once you've conceptualized, identify a project and thought about how they could work together, we felt like we needed some formative work to really interrogate that model and evaluate, what are the relevance of these constructs and how are they interrelated with each other. So we used a mixed methods approach to do this evaluation that included secondary analyses of existing quantitative data sets, which were pulled from a bunch of projects that we had access to. We also did primary data collection in the form of in-depth interviews with implementation partners, what we call key informants. They were HIV care providers, substance use providers, and other substantive experts, as well as people living with HIV who drink heavily and their social network support members. So a supportive person that they identified who would be eligible to participate in this intervention were they to participate in the trial. And I'll just summarize the key findings from each of those different activities. So the secondary analyses ended up taking a long time because we weren't able to conduct human subjects research for a while there. And this also was, funded during COVID, so there wasn't a lot of primary data collection happening. But it was, great in the context of a K Award where you need to, be productive and publish a lot. Collectively, we worked across numerous data sets. We explored multiple determinants of alcohol use. We looked at associations between alcohol use and HIV prevention and HIV care. I think collectively, these findings helped advance our understanding of the conceptual model broadly and how social context, substance use and M health engagement shape HIV transmission behaviors, both in terms of HIV prevention and care, and as well as their impact on HIV care clinical outcomes. I think that was helpful generally for understanding more about, substance use and HIV among people with HIV. But then we also felt like we actually needed specific information about how do you combine these two interventions, right? And so that's where primary data collection was extremely helpful. We conducted in-depth interviews with people living with HIV and a supportive person from their network, as well as with these key informants / implementation partners. And this was much more pragmatic, right? The focus of these interviews was to actually demonstrate the intervention to them, show them slides about each intervention components, and then really ask for open-ended feedback on how it could work to combine both this social support and M health approach to address both HIV care and alcohol use simultaneously. Big picture takeaways from that, I think there was broad support for a combined intervention. A lot of people acknowledged there could be benefit to addressing both HIV care and alcohol use simultaneously, that oftentimes their alcohol use can interfere with HIV care, but not always. There were also other priorities that people had and wanted at least consideration for reasons like why they might drink or other stressors in their life that they felt were important. A lot of the participants stressed the importance of trust, about accountability, and they wanted additional app features like positive reinforcement, space to reflect, links to other resources that aren't just purely alcohol related. The implementation partners talked a lot about potential barriers, perhaps limited social support among a lot of people with HIV. A lot of people living with HIV are lonely and isolated, as well as limited, resources in terms of implementing, an even more complex combined intervention. But we felt that both groups emphasized, the need and potential benefit to address co-occurring issues such as HIV and alcohol use, but also, mental health and other forms of substance use. So in summary, that formative implementation science research identified interest and support for this combined intervention. The findings were then used as step 4 of the combined EVIS process, which was to actually create a single protocol, a single intervention that addresses both of these things, right? So the goal of that stage was to develop a cohesive intervention protocol that integrated engage and health call core elements. Our process was to obtain source materials, protocols, manuals, training and fidelity tools, as well as resource referral pamphlets. We mapped objectives, theory-based techniques, core elements, and target outcomes across both of the interventions. We applied the designing for dissemination and sustainability principles to ensure contextual relevance, accessibility, and feasibility. And then we used the frame paper to make sure we were documenting all our adaptations, to think about what changes we were making, why, who decided those, and to figure out whether or not they were planned or unplanned. And our targeted outcome, we came up with a support sync, which is the name of this new combined intervention, which is designed to be virtually. It's a person-centered 1.5 hour baseline session with 2 follow-ups at 30 and 60 days. And it's guided by the information, motivation, and behavior, as well as the trans-theoretical model frameworks. And so, key decisions when we were in this process, using that designing for dissemination, we really wanted to reduce redundancy, right? We were trying to keep it short, able to be implemented in a real world setting. We wanted to try and enhance potential synergy. Because they were 2 different interventions with 2 different approaches, we had to harmonize tone and language across the interventions. And then we also had the opportunity to engage potential users and providers. So all the time we were thinking about trying to adapt for context, right? Making sure it was acceptable and feasible and culturally relevant to the folks we were working with and having discussions with about it. And then for step 5, even though at that point we had a combined intervention, a single protocol, we wanted to refine it through further feedback. So we collected feedback based on Proctor's implementation outcomes, objectives that included acceptability, adoption, appropriateness, and feasibility. We engaged consultants, both community-based consultants, potential users of the interventions, as well as implementation partners. A lot of the participants from from the original formative work remained extremely helpful. They raised key issues that we worked to address. We also had a cross core. We were able to present on the combined intervention and get feedback from folks on how we're going to actually implement the study to evaluate support sync. So that was, both of those were extremely helpful. This is just another table from the paper, sort of talking about what the by component of the new combined intervention, what the previous components were, what the key considerations we took into account, and what the ultimate combined intervention ended up being, and how we applied those designing for dissemination principles as part of that project. And I'll just end by saying we're excited about this process, this method that we've proposed. We hope people find it useful and take it up. But we want it to be considered another tool in the toolbox, right? So and we leverage a lot of the other implementation science frameworks, models, and tools, right? So we went through the implementation research logic model process with our new combined intervention to think about relevant determinants, implementation strategies, mechanisms, and outcomes, right? So this is not meant to replace anything, just to be an additional tool for folks who feel it would be useful. And our next step is to evaluate this, new combined intervention support sync. That's aim 3 of my K. Here's some of the details about, what it ended up being. It's, going to be a pilot RCT using a hybrid effectiveness implementation type 1 design. We're going to try and enroll 60 people living with HIV who screened positive on the audit C, as well as 30 support confidence in the intervention arm. Here are all the details. I won't go through them because I know I'm short on time. I just used my last few seconds to say all these resources are available in the paper online in the appendix, right? It's open access. And hopefully if people are interested in applying this process or feel it would be useful, there are tools available. So just thanks to all the people that help support me along the way. And I'm hoping that this, is a nice jumping off point for Cristina and Connor to describe their project on an actual example of an integrated care project.
This is it. Is that showing up on the screen?
Yes.
Okay, perfect.
You are great.
Hi, everyone. Thank you for having us. I'm Cristina. This is Connor. We've been introduced, and we are presenting on behalf of our co-authors. That includes Noelisa Montero, Emma Ramsdale, Francis Silva, Justin Knox, and Mary Irvine. And we want to acknowledge as well that we're in the research and evaluation unit, so we're not directly involved in program implementation. And so there are whole units within our program that do that work and are vital for the actual delivery of these services at a high quality. And those include QMPI and our EHE initiative services within our program. So, okay. Oh, and I want to say a little bit of background. So we are primarily funded by HRSA. And so we have the Ryan White Part A grant and the EHE grant, and then we get a bit of city tax levy funding, but that's a small minority. So most of our services are specifically for people already diagnosed with HIV. As a payer of last resort, we are not primarily providing medical services, which is usually covered by other payers like Medicaid. We're mostly covering all the wraparound services, all the other things that people need to be healthy. And this is a unique program, though, that we're going to tell you about because it's our one status neutral program. It's our one program where we're able to braid funding from Ryan White and from city tax levy funding and deliver services regardless of a person's diagnosis. And so that's exciting about it. And then I think I'm going to pass it on to Connor, though, to get into a little bit of the background of why we started this program in the first place.
Yeah, so as Cristina mentioned, we'll start with some background here on meth use and HIV here in New York City. So start us off here. Use of crystal meth has been increasing in the city, particularly among Black and Latino MSM. If you look at this chart here on the right, this is crystal meth use among MSM here in New York City, split up by race and ethnicity. And it starts in 2004 there on the left. And you can see from 2004 to 2011, it starts to decrease over time. But then from 2011 onward, this ends in 2017, you see it starts to increase again. And it starts to increase particularly among Black and Latino MSM. And we know that this increased meth use is associated with lower engagement in healthcare and lower viral suppression among people with HIV. And for people without HIV, this meth use is associated with increased risk of HIV exposure and reduced PrEP uptake as well. So then with this situation at hand, the health department implemented this program. The full name is the Crystal Meth Harm Reduction Services Program. We call it MTH for short. And it was implemented at 3 agencies in Manhattan and ended up serving participants from all 5 boroughs as well as the surrounding metropolitan area. And there were 5 main goals in this program. They were to reduce new HIV infections and improve HIV treatment outcomes, to provide health education and reduce harms associated with use, to offer support services and individual counseling, to link to clinical services for PrEP and PEP, HIV treatment and medication-assisted treatment, and to connect to mental health services for depression, anxiety, and psychosis. And so like I mentioned, there were 3 agencies involved. Clinical and medical services were available at one of the sites, and outreach and general supportive services were available at all the sites. Like Cristina mentioned, we had 2 funding streams here, one being federal HRSA Ryan-White Part A, and the other being local New York State and New York City funding. And because of that, we're able to do some interesting things. Like, there are limitations on each funding stream. And so because we're able to combine both of them, we can do things we wouldn't be able to do if we only had one or the other. So let's do some complementary service. And what those services actually look like, here's some of the core ones from the program. They look like HIV prevention and care services, direct medical services, substance use treatment, health education, and benefits navigation services. And I'll give you a second to read through some of the examples here. Okay, and then Cristina will be taking over for the methods.
So this was a retrospective descriptive evaluation, and we decided when doing that to apply the REAIM framework that many of you are already familiar with. And so we used it as a structured process to select our indicators or our metrics for the evaluation. We were limited, though, that we had individual client level data, so we were not able to have outcomes that were at the program level or the organization level. And we were looking broadly at enrollment, meth use, PrEP use, service utilization, HIV seroconversions, and others, and especially among priority populations. So we operationalized each of those domains except for the adoption domain. So reach was, the uptake. Effectiveness was short-term health-related outcomes and behavioral outcomes. Implementation was what services did people decide to engage with? And maintenance was what were the longer-term impacts of the program? So we issued an RFP initially, and we said to agencies applying for the funding that we especially want you to recruit men who have sex with men, transgender people, people not diagnosed with HIV, because this is meant to be status neutral, and people of color within each of these groups. And so everyone enrolling in the program did have to have reported meth use in the past 12 months. And then we further constrained the analytic sample to people who completed the intake form and people who had at least one service. So we use 2 primary data sources that we work with on a regular basis. One is called eShare, and it has all the client level programmatic and demographic data from everybody that gets services through Ryan White, through EHE, through other programs. And then for the HIV lab data, we match to the HIV registry. We do that routinely twice a year. And so many of you already know about implementation science. It's not strictly concerned with effectiveness, which is one of the great things about it. And it is a study of methods to promote the uptake of or integration of research findings into healthcare practice or into public health practice. And we're really seeking to address that gap between what's known to be effective and what is actually being used on the ground. So we had intakes that everyone completed, but then we asked participants to engage with reassessments about every 3 to 6 months. They were not required, though, to stay in the program. And so from that reassessment data, we're able to see changes over time For example, in reported meth use, in PrEP use, and in their sexual behavior. Now I'm going to pass it back to Connor.
All right, so we'll start getting into some of these results. So we'll be starting with the old program, which we call MTH for shorthand. This ran from 2017 to 2022. And we'll start off with demographics. So off the bat, we can say that the participants in the program reflect the populations most impacted. Over the course of the program, we ended up enrolling 545. Within this analysis, 545 people were included. The y-axis in the chart here is the proportion of those who match a certain characteristic. Starting with the leftmost, that's gender identity. You can see it's pretty overwhelmingly cisgender men, at 97%, with 2% transgender women. Next is HIV status. You can see it's not quite 50-50, but it's pretty close. Following that is race and ethnicity. In order there, we have the Black, Latino, and white groups. And then following that, our last one is sexual orientation. Again, we have another pretty overwhelming group here. It's the gay, bisexual, pansexual, queer, or questionless not sure group. And then 3% heterosexual people as well. Next, we have trends in the use of meth. Our key finding here is that meth use decreased among those reassessed. At enrollment, 91% of participants reported using meth in the prior 3 months, whereas at reassessment, only 44% reported using meth in the 3 months prior to that reassessment. And going further, we found that of those who had multiple reassessments, 70% of them reported no continued meth use between reassessments. And down in this table, here we have meth use at reassessment, but it's stratified by our priority populations here. And one thing I do want to call attention to is, well, you can see among the larger groups here, among the MSM, you can see that it's all kind of in the 40s, but there is, at Black MSM at 47%, and white MSM just under 42%. There's a little bit of a disparity here, and this is something we're going to see pop up again as well. So then up next, we have PrEP linkage and use. Our key finding here is that PrEP usage remained consistent. Nearly half of the participants were enrolled on PrEP at the time they enrolled. And at reassessment, it rose a little bit up to 58%. And so then again, down in this table, we have PrEP at enrollment and PrEP at reassessment for each of these same priority populations you saw in the last table. And here you can see that within each group, within each priority population, they remain pretty consistent over time for the most part. So that if you look at it across groups, you see these two highlighted cells here. Black MSM at 37.5% consistently, and white MSM at 53%. You can see that disparity definitely exists here, and is even more so than we saw in the last slide. And so the most utilized services in the program were health education. 88% of participants received a health education service, like a session. That was followed by benefits navigation at 85%, and then alcohol and other drug counseling at 79%. And additionally, medication-assisted treatment was provided to 10% of participants. And then next we have seroconversion. So we found that 6.7% of participants seroconverted over the course of the program. That comes up to 2.23 for every 100 person years. The good news is that most of these participants, at 88%, were engaged in care within 30 days, but only 35% were virally suppressed within 3 months after their diagnosis. And once again, we have another table. Down here, this is seroconversion, again split up, and you can see in the highlighted cells, this disparity once again exists. Black MSM seroconverted at 15% versus white MSM at only 3%. And so I'm happy to report that we have some preliminary data from the new program, which we call MTC, that started in 2022 at the close of the last program, and it continues to this day. But the data cutoff was the end of last year. So the program structure remains pretty similar for the most part. There's some difference in the agencies implementing it. So originally we had 3 in the old program in MTH. 2 of those agencies chose not to continue into the next iteration. So there were 3 agencies that started implementing the new program, but ultimately 1 discontinued it. So now there are 2 total agencies implementing this new one. And in terms of the implementation, the agencies were responsible for estimating the number of participants they would serve based on their capacity. But there were some limits here. The minimum number expected was 45, and the maximum allowed was 100. And during this whole startup period, we have the Quality Management and Program Implementation Unit at the Health Department. And they'll meet regularly with these agencies during the startup period to, answer any questions they have, to help out, to provide technical assistance they need to get back on track. And in 2025, a different team assumed responsibility for that, the Ending the HIV Epidemic Initiative Services team. All right, and so to get into some of the results here, we'll start with demographics like we did with the old program. To the end of last year, we have had 288 people enrolled. Once again, this is the same setup, the y-axis being the proportion of people who match a characteristic. Starting with gender identity, you can see it's a little different from last time. We have 80% cisgender men, 9% transgender women, 4% non-binary or gender non-conforming. And the next set of R's for HIV status, again, not quite 50-50, but pretty close. Following that is race and ethnicity. Here we have the white, Latino, Black, and Asian/Pacific Islander groups. And then lastly, on the right, we have sexual orientation. And again, this is a rather large group of gay, bisexual, pansexual, queer, or questioning/not sure. Participants at 79% and 17% heterosexual. And so next we'll get into meth use and MTC in the new program. Our key finding here is that fewer people use meth at reassessment, and meth use remained highest amongst the T, NB, GNC, and multiracial MSN participants. At enrollment, 90% of participants had used meth recently, as in 3 months. And at reassessment, 71% had used meth in the previous 3 months, while only 22% of those with multiple reassessments reported no continued meth use between those reassessments. And if we look down in this table, you can see this time it's a little different cells are highlighted. So here we have the multiracial MSM category and the transgender, non-binary, gender non-conforming groups, and there's another disparity exists here. It's a good deal higher than the other priority populations, and this is something we'll see again through these results. And then lastly here for the results, we have seroconversion in MTC. We found 4.7% of participants seroconverted in the first 3 years of the program. That comes up to 2.23 for every 100 person years. And the good news is that all of them, 100% of these participants were engaged in care within 30 days. And most of them, at 83%, were virally suppressed within 3 months. And down in this table, once again, same as the last slide, we can see that there is this disparity that exists here with transgender, non-binary, gender non-conforming people and multiracial MSM seroconverting at the highest percentage. And then next, I will leave it to Cristina to discuss some of these results.
Okay, good. How are we doing on time?
Good, 4 minutes.
Okay. Okay, awesome. So we're gonna do a bit of a recap of the findings. As we say, MTH is the old program, MTC is the new program. And we found successful reach for our priority populations in both programs. It shifted a little bit though, in terms of who was reached in the old program versus the new program. So in MTC, it was more diverse regarding sexual orientation and gender. In the old program, most reassessed participants reduced their meth use and maintained those reductions in meth use. Whereas in the newer program, we saw a lower reduction or a lower improvement, I guess, in the meth use and less consistent non-use. And then we found in the new program that transgender and multiracial individuals actually had some disparities that weren't there when we were looking at the old program. And then for PrEP, which we have not yet looked at for the new program, we found that PrEP uptake, like new uptake of PrEP was lower, but there was this consistency of PrEP use among those who were already on it. And this might be an explanation for why we have a high rate of seroconversions, which is on this next slide. So seroconversion rate was similar to a national cohort of sexual and gender minorities, but a fair amount higher than among MSM that reported to our sexual health clinics back in 2018. And then in the new program, we found engagement in timely HIV care happened with everyone actually that seroconverted, and then a higher proportion were virally suppressed quickly within 3 months. many important limitations, but these are some of the standouts, which is that we are working with observational data. It's a low threshold program. People get to engage with it as it works for them. This is not a manualized, protocolized, strict trial. And so you can imagine that the data is a bit messy, and we have to kind of work with its strengths as it is. And so it can be hard to tell, did people get reassessed because they had more stable lives and they were able to kind of engage in more elements of the program? And then about a third of our participants on that same topic were reassessed. So that limits our capacity to speak about the entire participant population and then how much our participant population is really reflective of the broader meth using population in New York City or outside of New York City. And so we want to acknowledge as well the agencies that have been involved in this program over the years, including Housing Works, GMHC, the Center, Callan Lord, and Aperture. Obviously, without their work, none of this would be possible. And so one question we want to leave you with is, again, the Q&A is, if we are to embark on a real thorough evaluation of the new program, MTC, given what you've seen, what would you be interested in us looking into? What would be of value for the field and for the people that are using meth? Thank you very much.